Sepsis is one of healthcare's biggest challenges, and like you, we understand the importance of early detection. You are on the front line in the fight against sepsis, and we at Radiometer are here to support you, especially in the emergency department. Our educational pocket guide can help you identify and treat sepsis early. To learn more, visit radiometer.com/sepsispct.
Greetings to you, our esteemed worldwide audience. I am Dr. Eleanor Wadinobi, the president of the Medical Women's International Association, a global association of female medical practitioners. I am deeply honored to be your moderator for this session. And so I warmly welcome you to session 9, our last session for the 2024 edition of the World Sepsis Congress. And this session is titled Challenges and Solutions for Early Recognition and Treatment of Sepsis. The aim of the session is to identify challenges and solutions of early recognition and treatment of sepsis, including presenting promising initiatives on the ground. I thank all our sponsors and especially the exclusive sponsor of this session, Radiometer. Before we start, some housekeeping information to ensure a seamless session. We have a lineup of erudite speakers, and as the moderator and accurate timekeeper, I will introduce each speaker in turn before their presentation. And after each talk, there'll be a brief opportunity for Q&A. And I invite you to please use the Q&A function by putting your questions in the chat. Their bios that I will use are very short, but we do have their very impressive bios, the full bios available on the website at WSCspotlight.org. Permit me to introduce, without further ado, our very first speaker for today. He is Dr. Patrick de Marie Katoto. He's Deputy Director of the Catholic University of Bakuvo Center for Tropical Diseases and Global Health in DRC. He's an affiliate researcher at the University of Cape Town Center for General Medicine and Global Health in South Africa. Dr. Katoto currently co-leads significant projects, including the Sub-Saharan African Consortium for Sepsis Research and Care, optimizing the implementation and scale-up of the WHO TB treatment decision algorithms for children with pulmonary tuberculosis in Sub-Saharan Africa. Over to you, Dr. Katoto.
Thank you very much, Dr. Eleanor, for the kind presentation. Today, I will present, some funding from our project. And here I'll try to understand risk factor for delayed presentation and care of sepsis patient in 3 sub-Saharan African countries. Key message here is, we have a high burden of sepsis in sub-Saharan Africa, and mortality and morbidities are both disproportionately, affecting people living in this region. We know we have different factors associated with this. Some are related to workforce in the region. Some are related to, financial burden, and some, very less known, are associated with access, limited access, and health-seeking behavior. This is why we have, the consortium called ARCS, the African Research Collaboration on Sepsis, to try to fill in some gaps. It's a huge concession with researchers from both Global South and Global North trying to engage trained clinicians, engage with key stakeholders, generating data, not only from hospital, but all the way, the pathway of the patient from house, from home, community to the hospital. There we have different studies, and today I will focus on BASIS and BASIS extension. BASIS, to start, that the baseline study for African sepsis incidence. It's a multi-country, short-period observational study of sepsis related admission in Africa. And here we went on 22 health facilities across 10 countries, namely Uganda, Malawi, Gabon, Sierra Leone, Ghana, Nigeria, Burkina Faso, Cameroon, and DRC. What was the objective? To estimate the incidence of sepsis, to assess the length of hospitalization and mortality, and assess available resources. And there we have also a sub-study where we assess actually patterns of pre-hospital healthcare seeking behavior and associated factors of delay in this population. It's a cross-sectional study, of 890 adult patients enrolled in the BASIS study. What did we try to understand? We need to improve treatment, but it doesn't start there. We want to understand why people are delaying consultation at the hospital. So if they are delaying, what are they doing before presenting to the hospital? Second, if they are going somewhere, where are they going to seek healthcare before presenting to the hospital? We know there is a sharp rise in non-communicable diseases and other comorbidities in Africa. So how are these comorbidities affecting presentation at the hospital? And collectively, what are independent risk factors associated with this delay? So we found that main reason of people actually delaying presentation at the hospital is first lack of literacy. Most of people, they don't know sepsis, what sepsis means actually. We are talking here about sepsis, but somewhere there in the community, people, they don't understand the illness itself. Further important, emphasizes the importance of health literacy. And you'll see the second the second reason here is no money for transport. And then no person to help me to reach the hospital. Fear of hospital care, etc. Quite interesting. And so I will zoom a little bit on, no money for transportation. This was kind of important findings. And we try to understand, okay, if this is the reason for delaying, very less studied. And so how people are reaching the hospital if they have sepsis, we will not hear that only 11% of this population could have the opportunity to reach the hospital via ambulances. But most of people are paying out-of-pocket money to go there. Some walking, some hiring taxi, some using motorbike, and some even, going in the minibuses. And so if they are going somewhere to seek for healthcare, where are they going? And this important slide will show us that we have both reasons, from patient to system delay. But it's very important to know that on the bottom of this figure, we found that most of important factors are actually system delayed at the primary health care. There is a very important retention of patients before they actually being referred to main hospital where sepsis can be a diagnosis. On the bottom, you'll find some very important factors like going to look for faith healers, going to for treatment with traditional healers, and in the middle, you find again money coming around, so financial constraint. When we try to look to all these reasons collectively and see what is coming in a model, we found that HIV people, those who are known with HIV, were less likely to delay their presentation at the hospital. This is something very important we have found here. A well-implemented program is really a window for patient contact and recognize earlier system as compared to those, with unknown HIV. And again, on the top of this, you'll find that almost 40% of delay related to traditional healer consultation. This is very important because now the WHO has recognized this, that African traditional medicine should be implemented, but in most of countries, they are not implemented these programs. And consequently, you see very important level of retention in there. So after conducting the basis study, we say, no, we understand, we find factors, very important, significant, but we feel that we miss something, patient and caregiver experience. So we say, let's extend the basis, and we design basis extension. This time was limited to only 3 countries, they are Congo, Nigeria, and Sierra Leone, to zoom in on a qualitative way with quantitative data again to understand this reason. So we try to identify and analyze the cultural, financial, systemic, and logistical factors that influence decisions related to seeking care for sepsis, and try to see the difference and similarity across countries. In-depth interviews was quite particular, as we did these interviews with caregivers and patients with sepsis after ICU, or even 7 days after discharge to hospital, if they couldn't talk during hospitalization. We have very wonderful data, but I will come out with just some quotes. One from a caregiver in DRC. He said, for lack of money, I hesitate to take her to the hospital. Finally, I said to myself that people will laugh at me if my mother dies in the house. In Nigeria, a patient said, my family insisted on taking me to a spiritual leader first when I fell ill. They believe my sickness was caused by a nerve spell. Going to the hospital was only considered after the condition didn't improve with prayers and traditional remedies. In Sierra Leone, a caregiver said, most times people in my community prefer to go to the pharmacy or traditional healer first because they believe the hospital will not give them the attention they need immediately. There is such a fear that hospitals are too busy or may not take their complaints seriously until very late. Very interesting, quotes from patients. So we have those interviews, analyzing them via NVIV on thematic areas, and we'll find some difference across countries, but also some cross-cutting insight. Where we have something like direct, indirect cost, both of them, showing the burden of financial constraint. We'll find some preference for traditional and spiritual healing methods, showcasing cultural belief and practice. And for example, fear of going there, stigma, psychological burdens, showing psychological barriers. So we have 8 thematic areas. And then we say, how do we, triangulate this with quantitative data? This is quite amazing when we see factors associated with this delay in this population. We have again, TB diagnosis. And this is very important, as some data from our previous colleague in Cape Town show that, even at patient level and system level, sepsis is very, very hard to diagnose among people with tuberculosis. And in this study, we saw that it actually tripled the odds of delaying for hospital visit. And secondly, again, paid admission fees. If patient knows that they will have to pay to go to the hospital, this doubles the odds of delaying. And thirdly, very important and significant funding here, prior antibiotic therapy, double also the odds. This is very important, as we have seen that previously people staying home, taking medicine, self-medication, etc. And if they are taking antibiotics, not only they are delaying treatment, but also antibiotic resistance. And this was doubling the odds of delaying treatment and hospital visit. And then those who presented SWITs, it's quite interesting, this symptom. For eligibility criteria, we have fever, prior antibiotics, malaria, sweat and rigors. All those other factors except prior antibiotic, and said the other didn't show significant association. This means that not everyone recognized that this symptom was actually related to impotent illness. And this again will trigger, conversation on health literacy. Sometimes nothing is very well. Doing nothing is quite important. We have seen that those who didn't initiate some actions, or going to look for treatment somewhere else, were also less likely to delay their treatment by around 29%. What did we find here? We note again complexity of barrier that impact actually timely hospital care for sepsis. Both barriers on structural and cultural factors have been relevant for these studies, and therefore call for interventions. What are we trying to do now is building another consortium that we are calling Sub-Saharan African Consortium for the advancement of innovative research and care in sepsis. Thanks to the German Federal Ministry of Education and Research, we've got a grant to run this study now, where we will build upon our basis and ARCS fundings to implement some new interventions to innovate sepsis in Sub-Saharan Africa. I'd like to thank the organization for inviting me, and for all the colleagues, Chevin, Jacob, Jamie Reliance, and all the ARCS, BASIS, and STEP collaborators. Thank you so much. Over.
Thank you so very much, Dr. Katoto, for that a very illuminating presentation. I don't see any questions at the moment, but thank you for the comment from Mohammed Osman from the UK, Abdul Rahman, saying Africa needs community and government helping. So with that, I'm going to now go on to our very next presentation by Wiltrud Abels. This is a pre-recorded video, so we apologize in advance that in this case, we will not be taking Q&A. Wiltrud is a specialist in anesthesiology and intensive care at the Charité University in Berlin. She is part of her department's telemedical intensive care unit that is actively supporting quality intensive care for sepsis patients daily, providing consultations for colleagues in intensive care in Germany and beyond. So please sit back and do listen to Wiltrud's presentation.
Thank you very much for the kind introduction, and welcome to everyone near and far. I'm coming in from Berlin in Germany today. Sorry for not being there in person. I'm delighted to speak to you today about the story of Sepsis Check, which is the sepsis checklist that was developed here in Germany with a view on the community and preclinical setting. Allow me to start with some simple truths. We know that most deaths from sepsis are avoidable. We know that a big majority of sepsis cases, at least in our setting here in Germany, is community acquired. We know that delays in presentation to the hospital considerably increase mortality. And unfortunately, we know that, at least in Germany, sepsis knowledge in the population is low. People do not sufficiently know what sepsis is, or how dangerous it is, how to prevent it. And if people have a certain level of knowledge, that still does not mean that they know when to act or when to seek emergency care. So there is a knowledge action gap. Now, in order to avoid preclinical delays and save lives, it seems crucial that people learn about sepsis, that risks are communicated, and that the presence of sepsis symptoms leads to action. Knowing all of this, and in the absence of a nationwide sepsis awareness campaign, or any public health efforts, educational efforts on sepsis, the German Sepsis Foundation in 2019 set out to conduct the Sepsis Wissen project. That translates to sepsis knowledge. In Sepsis Wissen, the team developed and tried to evaluate the role of evidence-based materials, evidence-based information materials in different formats to improve vaccination rates and sepsis knowledge in risk groups. Sepsis Wissen was a collaborative project between the Foundation, the German Public Health Institute, the Max Planck Institute for Education Research, and 3 big medical universities in the country. Obviously, with a limited budget and only, 3 years of time in the middle of a pandemic, we had to think a little on how to best bring evidence-based information to our risk groups. And social media, outdoor advertising, and our online information center on sepsis on the project website were important elements. But we also thought about a lot about the usual channels through which health information gets to the target population, who could act as information multiplier. And very early on in the project, we put an emphasis on addressing healthcare professionals, like GPs, nursing professionals, but also caregivers in nursing homes, family caregivers, and pharmacists, people we identified as to be in regular and close contact with the target population. We developed different training formats and materials that these multipliers then could distribute and relay directly to their patients in their practices, pharmacies, or institutions. We developed a theory of change model for our intervention and looked at the patient pathway in the region. And part of that process was to conduct piloting interviews with interested, healthcare professionals. And we actually learned a lot from their realities about typical patient pathways of people with risk factors for sepsis. And this is basically what led us to also develop a sepsis checklist, because one notion that came up repeatedly, particularly with nursing professionals and caregivers in nursing homes who cared for the elderly, was that they felt that they were not being taken seriously when calling emergency services for somebody who showed signs of deterioration or was developing sepsis. One of the interviews described what seemed to be a communication gap between EMS service providers and employees in her institution. And if you allow me to paraphrase a little, we know our patients well, we care for them every day, but when we see there's something wrong, we call the EMS, they very often don't take us seriously. I would like to have something to convince them, a list of things to show this could be sepsis, we need to do something. This resonated very well with the whole team, partly because we had heard these kind of stories before from sepsis survivors we work with at the foundation. But some of us also were actually involved in research projects on sepsis in preclinical care in Germany. And there was evidence on the way showing that, at least in some regions of the country, sepsis does not seem to be much on the minds of EMS providers. This particular study combined health insurance claims data of more than 100,000 people that had been actually diagnosed with sepsis in the hospital, with their respective documentations from the emergency medical services. And it was seen that paramedics had never, and physicians in only 1 in 1,000 patients documented a suspicion of sepsis, despite the fact that it was almost as prevalent as stroke and myocardial infarction, notably more deadly in the end. In addition, from a set of semi-structured qualitative and quantitative interviews that we conducted with health professionals in the Sepsis Wissen project, we learned that health professionals thought that the factors that would help or hinder them to transfer knowledge about sepsis to their patients or clients, so to speak, help or hinder them to become the channels of information that we wanted them to be, was, amongst other things, that sepsis was very difficult to diagnose and difficult to explain, and that it would be very helpful to have materials or tools to communicate better to their patients about sepsis. They also thought that it would be a helpful factor if people themselves actually knew more about sepsis, and also that they had tools, or that they would get tools to know when to act, especially in an emergency. All of this also pointed towards the potential usefulness of checklists. And yes, so here we were and set out to develop sepsis check as a tool to address the expressed need for bridging apparent communication gaps in the preclinical patient pathway, to also provide an educational tool to allow for communication about sepsis and to increase awareness, and to support the decision to seek emergency treatment for those that were unsure, by giving a tool that enabled people to realize, hey, there's a risk of sepsis here. I need to get some help. And so here we are. You can see the tool in use, and you can find this tool behind the barcode at the bottom, at the right bottom of the slide. Now, a few words about the development of the sepsis checklist. How did we design it? As you have seen, there are 3 columns representing risk factors, infection signs, and emergency symptoms. For the list of risk factors, our expert group that designed the tool first went back to available literature. There's a little incomplete list here on the left bottom of the slide, with some exemplary publications. We also went back to all the material that is out there in existing awareness campaigns on the information sites of CDC, Sepsis Alliance, WHO, GSA, all of those that you can see here. The second column are clinical infection signs, typical symptoms of localized infections. And in the third column, we have sepsis emergency signs. This part of the sepsis check draws from known symptoms of organ failure, like many of the awareness campaigns have them here, exemplary in the CDC materials, in their educational materials. But we also obviously looked for a way to incorporate the recommended detection tools and scores for mortality protection, like QuickSOFA, SEERS, Muse. You will certainly have recognized the elements of QuickSOFA in the sepsis check emergency signs that you've seen on the last slide. Notably, since we are in the community setting, or at least, outside the hospital, we only included those items that can be measured in a preclinical setting. So definitely not the leukocyte count that is part of SEERS. And also, importantly, with an emphasis on having a tool with a high sensitivity, because we're early on in the patient pathway, we decided that one item of QuickSOFA would be sufficient in sepsis check to trigger the recommendation to seek help. As we can see here, one positive QuickSOFA item is already enough to predict a mortality of more than 10%, and we don't want to miss those patients at risk. Now, after putting together the 3 columns, we did seek some feedback in terms of language, understandable language for lay people. And we used the German NGO, washab-ich.de, that has experience in translating medical records for and to lay people. In my opinion, a hugely important step when thinking about the educational purpose of sepsis check. And now let me share a little bit of the feedback that we had so far. First, from healthcare professional. In the Sepsis Vision project. This is from a structured quantitative survey. And when asked after 3 months of the trainings that some of the participants had been part of, which formats of Sepsis Vision they thought were helpful to pass on knowledge, more than 2/3 said that they thought the checklist was useful, even more than flyers, posters, or even the website. And when the same group was asked what they had actually used in the time that had passed after the training, the checklist also had resonated very well, better than flyers, posters, or going back to e-learnings. Also, in the qualitative interview, the perceived value of the checklist in communicating with patients was emphasized again. We are happy to say that we also gained political support. You can see here Dr. Stefan Schwarzer, who is the Commissioner for Patient Safety in the German government and a long-standing supporter of all the awareness activities, but also the sepsis checklist. And you can also see that Sepsis Check has found its way into the websites of the now existing national Germany Recognizes Sepsis Awareness campaign, which has been funded by the Ministry of Health since 2021. And last but not at all least, I brought some patient voices and reactions from people that we talked to about the checklists. Certainly, one of these occasions when we did that was the newly founded Patient University at our at our partner at the medical school in Brandenburg. People showed a generally high interest in learning about sepsis, but about the checklist also said specifically, with the checklist, I have something now. When something happens to me, to my family, maybe that can put me in a position to help. So again, here we have the aspect of enabling people to communicate about sepsis and to act. Okay, so at the very last, let me say that while evaluation of the sepsis check is still ongoing, I personally think that we are at a point that is the very beginning of the sepsis check story, and that there are a lot of open questions that we are not able to answer yet, but that we are waiting to be answered in the future. So first, about the effects of the checklist. Does it actually shorten preclinical delays? Is it able to identify patients at risks? Does it improve sepsis knowledge, of which we know that, as I said, at least in Germany, it is very low? There are certainly questions about the checklist itself that need answering. Is it comprehensive enough? Is it too comprehensive? What's the best format? We had feedback from people saying that there's too much text, too many items. We need icons and pictures. But we had also had people who said that it's very good that there's a lot of text because it's very educational. Younger people had a tendency to say, okay, we need an app instead of, the online interactive format. Older people sometimes preferred the printed version and to go through the checklist with a pen. So what about different target groups? What about language? I think it is safe to say that for the 16 translations that we have right now, there is some room for improvement. I'm very much inviting everyone here to have a look at the website, find their language if it's represented, and give us some feedback on that. And finally, just to lift the gaze a little beyond the German horizon and give a little outlook on one of the directions that we're actually trying to go with Sepsis Check, can it be adapted for use in other contexts or countries? Right now, we are actually exploring the use of Sepsis Check in supporting the epidemiological research in African countries that is conducted in the African-German Research Consortium on Sepsis that is called STARES, aiming to shed some light on the true incidence of sepsis in communities in Mozambique, Uganda, and Sierra Leone. We are exploring if the sepsis checklist, the German checklist, can add to standardized questionnaires and verbal autopsies in this regard. So with all of this, thank you very much. I'm going to stop here and say thanks a lot for listening. Again, I'm sorry to not be there live and in person. I'd like to answer questions, but I'm very happy to receive your feedback and questions via email. Thank you.
Well, another great presentation from Wiltrud on the sepsis checklists, in which she looks at healthcare professionals as channels of information. And lovely to hear that it has been piloted in Germany and now that they're looking at opportunities in Africa. At this point, I will now introduce our next speaker, who is Professor Glenn Hernandez Poblete, a professor in the Department of Intensive Care Medicine at the Faculty of Medicine, Pontificia Universidad Católica de Chile, Santiago. He obtained his PhD from the University of Amsterdam, and Glenn serves as the coordinator of the Latin American Intensive Care Research Network, LIVEN, and is the principal investigator for the Andromeda Shock projects. Professor Glenn, the floor is yours.
Thank you very much for this invitation. Happy to, I think, contribute a little bit to this interesting subject, of course, that it's very influential to care processes and diagnosis and monitoring for septic patients. Septic, I will not go in depth into pathophysiology. Of course, it's only 10 minutes, but just remark a couple of relevant aspects. When we speak about septic shock or acute circulatory dysfunction related to sepsis, there are basically two phases, early phases. The early phase where patients arrive to the emergency department in general with hypovolemia, predominant hypovolemia because of loss of vascular tone, which produces a fall in cardiac output and blood pressure and a fall in perfusion, hypoperfusion of the organs. When patients arrive at the emergency department in this early phase, they can be easily resuscitated. Usually they require just some fluid boluses or a little bit of vasopressors. and then they recover very easily perfusion, because in general, at that phase, it's a humoral phase, mediators are circulating, but the endothelium is safe, it's healthy, the same as the microcirculation, which is dry. However, unfortunately, some patients arrive late, or as was mentioned before, the process is recognized late, and then there is a diffuse microcirculatory derangement and dysfunction. And then even if you, the same, let's say, therapies that were successful in early phases fail to reperfuse the patient in late stages. And this, of course, increases mortality and morbidity. And there is we speak about septic shock, but in reality, it's a spectrum of presentation since very early, where patients arrive with the early signs, are particularly in some patients in adrenergic crisis, hyperadrenergia, and the patients look even hypertensive with bad peripheral perfusion, tachycardia, etc., and can easily be confounded with other diagnoses, even hypertensive crisis I have seen. But then if the process evolves, then it gets hypotensive, and then a perfusion crisis arrives, and then real septic shock. So you have to be aware that in early phases, and this requires training, of course, there are different, let's say, phases in which the patient can arrive, and then you have to be very and to manage and monitor the early septic-related circulatory dysfunction. It's all about, in reality, to manipulate hemodynamics, and hemodynamics is manipulating blood pressure with fluids and cardiac output, and sometimes early vasopressor to try to improve perfusion. And there we have problems. I will just a minute here, because it's easy to say this, because we can easily assess more and more macro hemodynamics, meaning mean arterial pressure, cardiac output. We can perform echo in many places around the world, and then have a very clear picture about how the cardiovascular system, the macro cardiovascular system, is functioning. But it's very difficult to assess what is happening in the microcirculation, in the periphery, in the cell, of course. And then we have to guess. We have to use surrogates that tell us indirectly that the patient has been reperfused. So it's always this what we call septic shock resuscitation has always a blind side. And the problem is that if we are not aware of this, and we do not select the most proper, let's say, resuscitation targets, then it's easy that with the force of resuscitation and with the impetu, we put too much fluids, too much drugs, and then we can increase morbidity and mortality as well, because of the consequence of over-resuscitation. So this needs, of course, a lot of teaching and practice and protocols to try to distinguish when a patient is still in shock or has been already reperfused. And there are several biomarkers or markers that have been used to try to indirectly assess what is happening in the periphery, in the cells, in the microcirculation. None of this is specific. All of these have problems. PCO2 gap and SCBO2 require central venous catheters that are not practical to be put in, placed in the emergency department in many places. Lactate is not always available. So peripheral perfusion, which is available universally, what we say, has gained a lot of popularity in recent years. On the other side, lactate, which was, let's say, the gold standard as a target for resuscitation or as a marker of hypoxia, has been challenged in recent years, because we now know, after several physiological clinical studies, that it has many sources, and some of the sources that impact persistent hyperlactatemia have nothing to do with persistent hypoperfusion or hypoxia, but with hyperadrenergia, some liver problems, etc. And as you see in this slide, we performed this work 10 years ago. We assessed several biomarkers of related to perfusion in patients that finally survived septic shock after we picked up only survivors. And you see that the columns represent persistent abnormality of different variables related to perfusion. And you see there are some variables like capillary refill time, for example, that is already normal at 2 hours in more than 80% of survivors, almost 90% of survivors, compared to lactate, which almost 50% of survivors have still abnormal lactates at 24 hours. So meaning that if you follow some, let's say, a little bit up to date, let's say, just not really active guidelines, until 2017, they proposed to normalize lactate as a goal for resuscitation. But you see, there is a huge difference in the time of you keep pushing fluids, etc., depending on the target that you select for this. And for this, peripheral perfusion has gained a lot of, let's say, impact and diffusion in the last years, because essentially, peripheral perfusion, we now know that it represents a very nice microcirculatory bed, and also because it has no metabolic autoregulatory control, it's just sympathetic control, so it goes up and down, and you can see, for example, if you look during reperfusion, during resuscitation, the skin, you can see, for example, in shock patient, not resuscitated, you see a cold, clammy skin. And then when you push resuscitation successfully, you see the transition from a cold, clammy skin to a warm, vasodilated skin with normal capillary refill time, disappearance of mottling, etc. And what you are looking at, in fact, is at the reperfusion in real time. So you can know, and this is based in many studies I have no time to mention now, that if you normalize peripheral perfusion, you probably have good chances to have normalized other more eventually important territories, such as the hepatosplanchnic, etc. So, and the beauty of this is it's simple, it's can be performed everywhere, and it's costless, of course. And there is a lot of studies that show that if you get a normal peripheral perfusion after initial resuscitation in the emergency department, for example, you normalize rapidly capillary refill time or mottling score, etc., you have a chance of surviving of more than 80-85% compared to only 60-50% in patients that do not normalize, reflected in this later case, a much more severe disease. And we demonstrated this in our emergency department some years ago, when in 100 patients that were admitted with sepsis-related acute circulatory dysfunction, we pushed this famous 30 mL per kilo of fluids, boluses, and patients that had a normal capillary refill time after this had a mortality, let's say, hospital mortality of less than 10% compared to 50% in those patients with persistent abnormal capillary refill time. So eventually, capillary refill time could be used as a triage, in the sense that if you give a rapid fluid bolus in the emergency department and it improves, then it probably implies that you have a simple circulatory dysfunction early phase and with better prognosis. But if it does not, probably you should go for a preferential triage to the ICU. There's a lot of studies now that show that a capillary refill time after a fluid challenge, for example, in patients that will survive, response in 10 minutes. 10 minutes tends to normalize, so it's a very fast responsive variable. Finally, there is a major randomized control trial, the Andromeda shock trial, where we compare lactate versus capillary refill time targeted resuscitation in more than 400 septic shock patients and early septic shock. We assessed capillary refill time, and this is highly recommended in the web. You can find many places where this technique is shown with the microscopic glass slide, pressing until the blanch, the oval of the index finger is totally blanch, and then you press until that, and then you maintain the pressure for 10 seconds, and then you stop, and with the stopwatch, you count the seconds where it takes to reperfuse. So this is the way we use it. And this, you know that we demonstrated that if resuscitation was stopped with a normal CRT compared to lactate, we had a 8.5 less mortality, or almost reached a classical statistical significance, less organ dysfunction. We gave less fluids because of posterior patient analysis. So we think finally that I think we have a very nice tool for the emergency department. It has to be trained. You have to know the physiology behind. You have to know some key aspects of assessment, and also how it responds to people that have a good response and people do not respond, in what time you should expect that. And it can serve you a lot, and maybe it will change how you manage this problem in the emergency department. Thank you very much.
Wow, thank you, Professor Glenn. Truly fascinating what you've shared with us today and how you've, achieved reduced mortality. You've left us with the message that we are truly heterogeneous. I don't see any questions from our esteemed audience in the chat for you in particular. I remind you to please do put your questions for the speakers in the chat. Thank you again, Professor Glenn. And I'll now turn over to Flavia Machado. Professor Flavia Machado is a professor of intensive care and chair of the intensive care section of anesthesiology, pain and intensive care department at the Federal University of Sao Paulo in Brazil. She has been working with the Latin America Sepsis Institute, LACI, since its foundation in 2005. LACI is devoted to the quality improvement process and knowledge translation in Brazilian hospitals, as well as to coordinating multi-center studies in the sepsis field. Over to you, Professor Flavia.
Thank you so much. It's a pleasure to be here again. And thanks to Global Sepsis Alliance for organizing this meeting and for inviting me. I was asked to discuss a little bit about emergency departments, sepsis in emergency departments here in Brazil. We did a study recently about this. And the reason why we performed the spread in emergency department study was our previous study done in a random sample of Brazilian ICUs, in which we found out a high prevalence and high mortality rates here in Brazil. After this study, we were able to find that what happens everywhere, and I think that in middle-income countries, actually, the percentage of patients that comes from the emergency department to our ICU might be even lower than in high-income countries, because we do have a lot of problems with nosocomial infection. But anyway, in that study, 34% of the patients came from emergency department. And the mortality rates were very high for those patients. One of the potential reasons for this high mortality rate, we know, is what Dr. Katoto just mentioned. It's delay in reaching care when we have community sepsis. And the reasons for that were brilliantly explained by him. There are a lot of problems in the decision to seek for care, decisions to reach in care, and also delays in receiving adequate care. And after being there, there's a lot of problems in our emergency departments with ED crowding and ED burden. We have the chance to revise this issue of ED burden. It's going to be in next couple of months published in Equivalent Opinion in Critical Care. But all these problems certainly compromises our capacity of dealing with those patients in emergency department. And mainly in receiving adequate care after reaching care. Because at least in Brazil, many times those patients are seen what we call standing emergency departments, meaning that they are not in a hospital. They only have the emergency care, and then they have to transfer these patients to hospitals, either through admission in wards or in ICUs. And then what we did, we look at our database before the pandemic, and among the 37,000 patients that we have, 6,000 of them were transferred from one facility to another. And in a multivariated model, just the fact that those patients were transferred, together with all other risk factors, was associated with a 1.4 higher chance of dying. And this happens either in the private or in the public system. Certainly the odds to dying because you are transferred are high in the public system. So all of this made us try to design this paper that was published last year. which is the sepsis, the spread in emergency department. It was done together with the Brazilian Emergency Societies, and it was a prospective multicenter observational study in a 3 days, it's a 3-day prevalence study in these emergency departments. And differently from our study in ICUs, we are not able to perform it in a random sample of emergency departments. We did not have a list of the emergency departments in Brazil as we had for ICUs, so we did it in a convenient sample. The design of the study was to assess every day, 3 days in that specific week, all patients that had been admitted with sepsis, which we call type 1, whatever, but acute admission for sepsis. But we know already that the burden would not be on the patients, not be only on the patients admitted with acute sepsis, but also those patients that were admitted with sepsis and stayed in the emergency department because they were not able to be transferred to a ward or to an ICU, which is the measuring of the ED burden. Burden means the patient has already been indicated to go, for instance, to an ICU or ward, and it's the time that he spends in the emergency department waiting for that transfer. And we also try to measure another burden, which is patients that are in this ED burden, meaning they are in the emergency department. They were admitted for another reason, which is not sepsis and it's not infection, meaning a stroke or MI or whatever, and they complicated with sepsis as an acquired infection while they were staying in the emergency department. So we tried to measure the 3 burdens. We started with 150 institutions that collected data on organizational issues, but only 74 were able to collect clinical data. In this convenient sample, this means Poblete. This probably is a proxy of better units that were able to organize themselves to collect the data, meaning that the results of this study might be biased in 4 of more qualified institutions. We had 32,000 ED admissions during these 3 study days on the participating emergency departments and a total of 331 septic patients. And they were equally divided between those acute admissions, 55% were acute admissions with sepsis, but almost 50% of the ED burden where the burden was ED boarding, meaning that there were patients that were staying in the emergency department without being admitted in the hospital. And the overall mortality was 32%, which for patients in emergency department, which most of them had community sepsis, it's a very, very high mortality rate. We also thought to understand what was the allocation patterns, and only 52% of those patients were appropriately allocated within 24 hours, meaning if they had an indication to go to a ward, they were admitted in the ward, or if they had indications to go to the ICU, they were admitted in the ICU. And there was a disproportion on this proper allocation between public and private. ICU admissions within 24 hours happens only in 15% of the patients in the public system, within a mean of 18 hours of ED boarding before being in the ICU, only for 50% of the patients. And of course, in the private system, more patients were admitted in the ICU within 24 hours. The main reason for not being admitted in the ICU was the availability of ICU beds. And also in the private system, one of the main reasons is lack of healthcare insurance. They have to wait until they get a transfer to a public hospital. And one of the most interesting findings on this study is that we also asked the sites which was the immediate location after ED. In the public hospitals, you can see this in this line, and in the private hospital, it's the below imaging. And what we are seeing here is a complicated figure, but we can follow it. For instance, in the public hospitals, patients were in the emergency department and part of them were transferred to another facility. Some of them, as we see, were finally transferred to an ICU, not within 24 hours, but they were finally transferred to an ICU. Some of them were finally transferred to a ward within the hospital admission. But 40% of those patients stayed in the emergency department, were totally treated in the emergency department within the whole hospital stay. And 60% of those patients in the public institutions died in the emergency department. And this was not that immediate, the early death that we also have, certainly. 7% of those patients died within 6 hours of hospital admission. But some of these patients died in a mean time of 2.7 days. And some patients stay in the emergency department up to 13 days until they finally die. The main reason why they were never admitted in a ward or in an ICU was the lack of an ICU or ward bed. Some of them were also in end-of-life care. Mortality rates, as I said, were high, 32%, and it was almost 40%, or more than 40% in the public institutions. It was different from public to private. Certainly, this is a convenient sample. It's different from our study in the emergency ICUs, where in the random sample of ICUs. In that random sample, we could not find differences between public and private, but here, in that convenient sample, it seems that the mortality rate in the public institutions is really higher. And the mortality rate for those who were admitted with acute sepsis, it was lower, only 22%, in comparison with those who had a prior diagnosis of sepsis and were in the emergency department when they developed organ dysfunction, and those who had a sepsis as a complication of their stay, meaning that they have a nosocomial infection. The main factors associated with the risk of dying were the type of infection, meaning that those patients who had healthcare associated infection manifested in the community, meaning those patients that are in a renal replacement therapy or had a prior admission in another hospital, they have a higher risk of dying. And also being in institutions with lower viability of resources, which means having less than 6 of 8 items that we consider necessary to comply with the 1-hour bundle, was also a risk factor for higher mortality. And being in an institution with an accreditation status, meaning that this is the proxy of a better quality of care, was associated with a lower chance of dying. The strength of this study is that the data was prospectively collected in a middle-income country. It's a multicenter study. We assessed the whole ID burden and not only those acute admissions, but certainly there is a problem in our convenient sampling, meaning that if we had made this in a random samples of emergency departments in Brazil, I would say that the results were going to be even worse. But although this might be the scenario that we can find in some of the public emergency departments in Brazil, we believe that there is a way to go. And this is, for instance, the database of LASI up to 2019, and only emergency department patients, 72,000 patients. And we see that either if you are in a public or a private institutions, the mortality rate along the years in LASI database has been decreased, which is a very good sign of that we can change this reality. So my take-home message is going to be that the burden in the emergency department, mainly in our public hospitals, it's significant, and I believe that we are quite similar to many other emergency departments in low and middle-income countries. Our allocations patterns are very inadequate, as we expected. The mortality rates are high and they are related to the severity of illness, but it's also possible that the fact that these patients are not appropriately allocated contributes to this high mortality. But we know that if you know the burden, it is the best way to keep going forward. This is the first step because we can change this reality. Yeah, and we are already doing this. Thank you very much again for the invitation.
Thank you so much, Professor Flavia, for that very insightful presentation. And, reminding us that, once we can know the burden that we have in our EDs, that we can better provide a solution. I will now call on Professor Mark Ansermino, who is a professor in the Department of Anesthesiology, Pharmacology, and Therapeutics at the University of British Columbia, and is the Executive Medical Director of Global Health at British Columbia's Children's Hospital in Vancouver, Canada. He was also a Michael Smith Foundation for Health Research Scholar and the Brockhouse Canada Prize for Interdisciplinary Research winner in 2011. As I said earlier, we do have extensive bios of our erudite speakers, which you can read more about on the website. But let me now hand over to Professor Ansermino.
Thank you very much, Eleanor, and thank you to the GSA for inviting me to give this talk on some of the most recent research we have been doing on triage in children. I have no conflicts of interest. First of all, as we've heard today, sepsis is a huge problem globally, and early recognition is really important when it comes to delivering supportive interventions. And we know this is often missed, particularly in busy emergency departments. We also know that thresholds of vital signs or other measurements are used sometimes to try and trigger indications of sepsis, but we know that this is not very reliable. So there's been a lot of interest in having smarter tools that we call trigger tools that can combine clinical signs and vital signs to assist in early recognition of sepsis. And of course, to make this globally applicable, we need to be able to do this in low resource settings, particularly where people have lower levels of training and obviously where they have less time as well. So this is what we've done with the Smart Triage program that we've been working on for nearly 10 years now. And we've combined this with the Quality Improvement program because it's no use identifying a sick child unless we can actually provide that care in a more timely fashion. So in the usual standard of care, we have each child being treated on a first come, first served sort of basis. And the idea of triage in the purest form is we take the sickest children and we take them to the front of the queue. But ideally, we want to be able to identify those children very quickly and easily. And we use this digital tool to be able to do that. And in developing this, we targeted an intervention that would take less than 5 minutes. So this is very rapid intervention. It can be done even by an untrained student nurse to be able to do this triage. And what we do then is we try and prioritize the care of this particular child. And the quality improvement programs that we married with this were really around workflows in the outpatient or emergency departments, and also looking at obviously educational training within the facilities and looking at where the bottlenecks are. So the digital platform we use for this, in fact, has 3 components. It has a mobile application. It has a what we call Smart Spot, and I'll talk about that, and it has a clinical dashboard. And all of these are combined at the end of the day to really drive this quality improvement. So the app has a number of screens, initially with danger signs, which are based on the ETAT danger signs. We have some independent triggers, particularly around vital signs. And then we combine some of the history, the symptoms, the signs, and the vital signs with a predictive algorithm that's able to tell us which children should be classified as emergency, urgent, or priority. And it also does a full nutritional assessment with this information, which we know is really an important indicator of children at risk. And this is the final output of this triage application. It's all based on the risk of admission, and it will give you the percentage, the likelihood that this child would need admission. And at each facility, we customize these thresholds to really suit the capability of that facility, like how many emergency patients can they handle within a day at a time, how much space do they have, and it also depends on the baseline risk at that particular facility. So we adjust these thresholds of this risk algorithm. What does this algorithm look like? So this is a study that we did to develop the algorithm on over 15,000 children that we collected over 100 variables on each child. And from that, we developed this 9-variable model, which is based on simple things that we think would be important: the heart rate, the temperature, the mid-upper arm circumference for nutrition, oxygen saturation, age, parental concern, which in actual fact proved to be really important, difficulty breathing, edema, and pallor. And based on that, we can predict the risk of each child. So this has been extensively externally validated as well. So the Smart Spot system, which is the second component of the system, is really a dongle that the mother wears around her neck on a lanyard, a colored lanyard, that really lets everybody know what status this child is at, what triage status this child is, but also this location beacon allows us to know where each child is in the triage system so they don't get lost. And this then gets displayed on this clinician dashboard, which is available to, on large screens in the emergency or outpatient department, but also at the clinician workstation, as it can be at the administration, it can be in the nutritional assessment unit, it can be in the pharmacy or the laboratory. So everybody can know what the priority of each individual child is. And this is a simple web page that you can even get on your phone as long as you have access. It just runs on a local server. So initially we did a feasibility study at the Holy Innocents Children's Hospital in Uganda. We did a pre-post study where we did 11 weeks, where we just collected pre-implementation study. We then implemented for 11 weeks, and the primary outcome was the time to treatment. And we really showed that we could significantly reduce the time to treatment in these children, and particularly reduce the time to treatment of the emergency children. So then we wanted to take this to a larger study. So we designed a much bigger multi-country study that we did in Kenya and Uganda. And in addition to that, we had controlled intervention sites. And in this study, we looked at just under 20,000 children. And we once again target time to treatment as the primary outcome. In this larger study, we did see some inconsistency in the change in treatment times. And this was obviously impacted by the COVID-19 pandemic. But I think what was interesting that at every site during the control period and at the control sites, there was a significant reduction in treatment times. But I think the most interesting part about that is that certainly in intervention sites, there was improved time for emergency cases. But most interesting is that there was a very significant reduction in antibiotic utilization of 47% in Kenya and 30% in Uganda, reduction in admission rates from 47 and 33% of the two countries, and even a reduction in mortality just from this intervention. Of course, this is not just the Triage app. This is obviously the quality improvement program that is going on. And because these were secondary outcomes from this study, we need to evaluate this in larger studies looking at these specific outcomes. But I think you would agree, this is really encouraging that by combining this triage with quality improvement, we can significantly reduce mortality. So what did the health workers think? So first of all, we did some work looking at this. They certainly found that it was easy to do, useful for them to use, improved identification of emergency cases, and they really found that this data collected helped them with their quality improvement processes, as well as their clinical management of these cases. So how much does this cost? I think that's important. So we did look at the cost effectiveness of this, and the average implementation over a 5-year period is something like $1,500 or about 5 cents per triage. And that includes setting up the server and this beacon detectors, which is not an essential part of the system, but obviously makes tracking patients and treatments much easier. And if you look at the cost effectiveness, because we reduced mortality rates, in actual fact, this is 100% cost effective. And we, in fact, save $15 for every year of life lost. So in other words, this is extremely cost effective to be able to implement. So we have now extended this to other facilities. And obviously, we're learning how to implement this much more in real world settings across Uganda, combined with our Smart Discharges program. And we hope to see this implemented in other countries in the near future. Thank you very much for your time.
Thank you very much for your really interesting presentation. And we've got two questions that have come in for you, and I'll take them together. From Jackson Juma in the USA, he says, can intelligent triage assisted by risk scores, such as the Apache score, restore early recognition and triage of seriously ill patients in emergency departments in Africa in general? And then Laura Alberto from Argentina says, what is the cost of the technology to implement the smart triage? Would that work in adults?
Yeah, thank you very much for those questions. And yes, I think that, the future of healthcare, as we've heard in a couple of presentations today, is all about using data to improve these risk prediction algorithms that we can use in the emergency department. And I think that's relevant for children and for adults. Of course, the diseases we see in children and adults are different, so the risk scores themselves are going to be important to be able to adapt to those settings. But I think the message that I've tried to bring in the presentation today is that just having some score that we can have, it may be a very intelligent score that can predict an outcome. It's no good just to implement the score unless you're taking action based on that score. And I think the answer to both those questions, yes, we could do this in adults. We will need a different risk prediction algorithm. But I think a lot of the lessons we've learned of how to implement this in this setting is totally applicable to adults. So we need to work out why these patients are hanging around the laboratory, why they're not getting their treatment from the pharmacy in time. We need to look at all of those things. And I think that would be no different in an adult setting compared to a pediatric setting. And certainly this is obviously implemented in Africa. This is very doable. There's minimal training required for doing this. We even talked about training the gatekeeper to be able to do this triage. That's how simple it is to be able to use this app. Thank you.
Thank you so much. Thank you. I really wish we had more time. But here we are now at the close of the Congress, and there is no other person than Michael Wong, a recognized healthcare and patient safety expert, to do that, carry out that assignment for us. And Michael has been at the forefront in advocating for practical solutions. And I emphasize that. Practical solutions that reduce healthcare costs, reduce the number and severity of medical errors, and improve patient health outcomes. Michael is the executive director and driving force behind the Physician-Patient Alliance for Health and Safety, PPAHS. Over to you, Michael.
Thank you, Eleanor, for your kind introduction. As you said, I'm the founder and executive director of the Physician-Patient Alliance for Health and Safety. First, I'd like to thank all of the speakers for their excellent and thought-provoking presentations, to the Scientific Advisory Committee for their advice and recommendations, and as well for all of the folks who have worked to organize this wonderful spotlight on the unmet need of sepsis detection and treatment. I hope that you have learned a lot. I know I have over these last 9 sessions. I perhaps might not have gotten as much sleep as it started very early here in the East Coast in the United States. But more importantly, I hope that all of you have learned and will apply these learnings in your practices every day going forward. If you'd like to earn free, and I emphasize free, continuing medical education credits, our accrediting bodies is approving the spotlight sessions for CME And these will be available in about a month's time from now. So if you'd like to earn CME, free CME for watching the Spotlight, please come back to our website, www.ppahs.org, around the end of the month in May. So thank you so much for being part of the sepsis solution. And thank you again for the marvelous presentations we've heard over the last number of hours. And with that, I turn back to you, Eleanor.
Oh, thank you so very much indeed, Michael. As you know, it goes without saying, really fascinating presentations, illuminating, thought-provoking in several ways. And I encourage you, our esteemed global audience, to visit our website. Please do sign the World Sepsis Declaration if you haven't done so already. Follow us on Facebook, Twitter, Instagram, LinkedIn, and TikTok. I thank again our wonderful sponsors. I thank again our erudite presenters. I thank again our esteemed audience. And I thank again myself, the moderator. All the very best.